I will try to present an overview, a quite superficial overview on the state of the art of fertility preservation. And as you said, this topic will be covered in depth tomorrow morning during the presentation that you are going to listen. And I would like to, I would like to start to presenting some comparative data between childhood cancer and adult cancer, because clinical situations that we will have to deal with. We know that childhood cancer is a rare disease. It's more or less is 1 in 100 adult cancer. In Spain, we have a register of childhood cancer, and we have 900 new cases every year. And in developed countries, childhood cancer is, after accidents, the most common cause of child death. But we are lucky because they have children affected of a cancer, they have a good survival rate, around 75%. And this means that 1 in 1,000 young adults will be a childhood cancer survivor. Here we have information on how, in the last 2-3 decades, the survival rates after childhood cancer have improved. All kinds of cancer, apart from the acute myeloid leukemia. And what happened with adult cancer? Here we have information from the US on the most common cancer affecting women, fertile patients, and you can see again that there is a clear trend of improving survival in the last 2-3 decades for the most common cancers that normally affect young women. In our own experience, in our center, considering breast cancer, out of almost 3,000 breast cancers, 6% of them were cancers affecting women under the age of 36. So most of them without having their motherhood fully accomplished. And another important aspect is both childhood cancer and breast cancer cancers are the 2 situations in which more years of life can be saved, thanks to the modern therapy and radiotherapy. And this is important. This is a relevant clinical issue to be considered. And if we look at the childhood cancer, we switch from life-threatening events to life-altering events. And some of those children surviving the childhood cancer, in their adult period, they will suffer from different conditions, and one of them is infertility. And this is why we are concerned on preserving fertility of both these young patients and adolescents and adult patients as well. So we mainly will concentrate our efforts in 3 different clinical situations: preserving fertility in non-oncologic patients, second, preserving fertility in oncologic patients, and third, applying these techniques to preserve fertility for social reasons, for those patients deciding to postpone their fertility, mostly for the development of their professional career. What happened with non-oncologic patients? We know that there are different clinical situations in which the treatment that we must apply will interfere with the future fertility of these patients. We have clear evidence that those patients receiving bone marrow transplantation for different benign hematologic conditions, single-cell anemia, thalassemia, aplastic anemia, or autoimmune diseases unresponsive to immunosuppressive therapy, those patients with bone marrow transplantation probably will require a previous fertility preservation. Patients with autoimmune diseases, rheumatoid arthritis, Behçet's disease, Wegener disease, etc. Patients with benign ovarian pathologies, recurrent ovarian cyst, endometriosis, ovarian torsion, patients with endocrine or genetic diseases, Turner syndrome, family predisposition to premature menopause, and another recent indication is for transsexual patients before treating them with sexual reassignment surgery. To these patients, it must be offered as well fertility preservation. What happened in oncologic patients? We know well that different malignancies have different risk of permanent ovarian failure after the treatment. And for those conditions with medium and high risk of premature ovarian failure after the oncologic treatment, fertility preservation must be offered. And what happened? Why the oncologic treatment negatively affects the ovary? There is a very interesting review and study published recently in Human Reproduction Update, in which the authors clearly suggest how chemotherapy affects ovarian function. And as you can see in this cartoon, there are two different targets. One is how chemotherapy has a direct action on the primordial follicles, and it has also an indirect action because the drug damage the growing follicles. This means that the turnover, a faster turnover of primordial follicles and a higher consumption and reduction in the final number of primordial follicles. But chemotherapy has also a direct effect on the oocyte itself, damaging the oocyte and leading to oocyte death, as well to the somatic cells surrounding the oocyte, and in the end, inducing as well oocyte death. And we know in the literature, you will see there is a lot of evidence on how radiotherapy or different chemotherapeutic drugs affect ovarian function. This is why we need to assess the ovarian reserve in oncologic patients before starting treatment and before starting any fertility preservation strategy. And another important point is the effect that those patients receiving pelvic irradiation will suffer from sometimes a permanent damage on the endometrium, on the uterine muscle, on the uterine blood supply, and we have from the same authors, Amish Wallace and Romero, they have clearly shown how endometrium was in sometimes permanently damaged by pelvic irradiation used for the treatment of any malignancy. So the message is that gonadal damage is dose and age dependent. The older the patient is, the higher the damage will be. So from a clinical point of view, when you have a young oncologic patient asking you information on the different strategies that we must propose to her in order to preserve her fertility, we must consider the age of the patient, we must consider her basal ovarian reserve, the type and stage of the malignancy, which is the proposed therapeutic plan. If he has to receive chemotherapy, we need to know the type of drugs, the dose and the duration. The same for radiotherapy. We must know if she will be operated on, which will be the foreseeable long-term effects, and we must know if it's possible to delay the start of chemotherapy, giving us 1 or 2 weeks to do something before the start of chemotherapy. Is it possible for this patient to receive ovulatory agents? Which is her social situation? Is she alone? She has a partner? And of course, we must know the biology of the tumor and the possibility of ovarian metastasis. We have more and more information that some or quite a large proportion of young oncologic patients, before starting chemotherapy or radiotherapy, they already have a reduced ovarian reserve. And some recent publication for lymphoma, but for other malignancies, have proved that some of these patients already have a reduced ovarian reserve before starting chemo or radiotherapy. And the best tool to monitor the evolution of this ovarian reserve is, for sure, measuring AMH. It's much better than FSH. As you can see here, comparing two groups of oncologic patients. Patients suffering from malignancy with a high risk of posterior ovarian failure and patients with medium of low risk. For patients at high risk, both AMH and FSH do well, both measuring before starting the therapy, at the end of the therapy, and 6 months later. You can see how AMH is significantly reduced and FSH is significantly increased. But for those patients in the group of medium or low risk malignancies, you can see that AMH is clearly much better, is a good marker, much better than FSH. Which were the classical strategies that were proposed to these patients? It was a publication from 2006, and as you can see here, the only established or clinically accepted strategies were embryo cryopreservation, gonadal shielding, ovarian transposition, and fertility sparing surgery. But at that time, in 2006, most of the experimental strategies to be proposed at that time are nowadays already clinically established and accepted, such as oocyte cryopreservation, oocyte ovarian cryopreservation, and posterior grafting, and this is a matter of controversy, ovarian suppression with GnRH agonist. So if we consider the prevention of gonadal damage, how can we do it? How can we protect the gonad of the effects of the oncologic treatment? We can reduce toxicity, and for reducing toxicity, we, in case of pelvic radiotherapy, we must suggest to have an ovarian transposition. In case of chemotherapy, we can use either a less toxic chemotherapy, if possible, or at lower doses, but being efficient, or we can use a gonadal protection with a GnRH agonist. I will come back to this point later on. What happened with ovarian transposition is an easy surgical procedure that can be done by laparoscopy in case of patients suffering from tumors requiring pelvic irradiation, or both ovaries can be easily placed in the lateral part of the pelvis, and the key points are it's very important to preserve ovarian vascularization, otherwise you will add a factor of reduction of blood supply to the ovaries, and you will induce a reduction of the ovarian reserve. It's important to leave the ovaries in an easy position for possible future ovum pickups, and maybe you can take advantage of this laparoscopic procedure to retrieve fragments of the ovarian cortex and to freeze them. The issue of gonadal protection with GnRH agonists is a permanent matter of controversy, and it's not clear because the good results have not been reproduced worldwide. Some authors, like Blumenfeld, have shown a significant reduction in the percentage of of premature ovarian failure after chemotherapy compared to controls, and much better results than those obtained with oral contraceptive in these patients. The second strategy we have is to use cryopreservation. Cryopreservation of embryos of oocytes of ovarian tissue. With embryos, we know well, very well, these are data from our standard embryo cryopreservation program. We know that the frozen time is not relevant for the survival and implantation potential of these embryos, and we can see here embryos being frozen for more than 5 years have exactly the same pregnancy rate after thawing and replacement than embryos with less shorter period of frozen time, and we have a baby born 14 years after cryopreservation. With oocyte cryopreservation, this issue will be covered by Dr. Noyes tomorrow in depth, but there are some, it's a useful technique, and nowadays probably is the present better tool that we can use. It was mainly used in case of post-pubertal patients, but there is a recent publication in Fertility Sterile by Redman and co-workers in which they have used this strategy in a pre-pubertal girl before the menarche, and they, if I recall well, I think they have retrieved 16 or 17 oocytes in a young girl that before the menarche. In cases, of course, in which there is no contraindication for ovarian stimulation, and in cases you have time. The advantage is that no need for partner or for accepting donor semen. The drawbacks, if you want to be really efficient, you need to vitrify or to freeze, ideally more than 10 oocytes, and the classical results with those slow freezing were poor, and vitrification has significantly changed the potential outcome of this technique. In fact, we have had last July the live birth of a healthy young baby in a patient in which she was operated on from invasive ovarian cancer, and in which oocytes had been vitrified. 2 years later, oocytes have been worn, inseminated, and embryos were replaced, and this pregnancy was established and delivered uneventfully. For these cases, of course, there is a clear consensus that if you are dealing with a patient suffering from an hormonal-dependent cancer, this is the ideal ovarian stimulation protocol in which patient must be stimulated with a combination of aromatase inhibitors, letrozole we use at a daily dose of 5 milligrams, plus 150 reg FSH per day, and under GnRH antagonist. Final triggering is accomplished by a bolus of GnRH agonist, and after ovum pickup, you can continue either with letrozole or with the antagonist in order to shorten and to induce the menstruation and the final of the luteal phase. Here we have information from Kudlow-Cocktail group in the US, in which he clearly showed that by triggering these patients with a bolus of GnRH agonists, results are much better, as we heard this morning, in normal patients. And you can see here that the number of mature oocytes is improved. The oocyte maturation rate is significantly improved. The number of 2PN embryo, the fertilization rate, the drop in estradiol is improved, and the risk of mild to moderate OHSS is significantly reduced. So nowadays, we can consider that it's mandatory to use this combination of GnRH antagonists, aromatase inhibitors, triggering with a GnRH agonist in patients with hormonal-dependent tumors. we know that those patients receiving a combination of generase antagonists and aromatase inhibitors, because they suffer from these hormone-sensitive cancers, they produce less estradiol and significantly low number of oocytes are retrieved from these patients. But this difference disappears with this protocol if we consider not only patients suffering from hormonal-dependent cancer, but for all kinds of cancers, as you can see here from this meta-analysis published by Tulandi and Holzer in Canada, the differences disappear. So I think that these protocols are efficient, they are easy to be followed, and these protocols are safe because we know from data from Kudukoktai group in the time in the New York hospital, they compare how do patients being stimulated and in which oocytes or embryos have been frozen compared to patients who, breast cancer patients, who were not stimulated, who were not, just were followed up after the oncologic treatment, and the recurrence rate was almost the same. Okay, so what do we have nowadays to propose to to a given patient? We think that for the currently available information does not seem that in certain cases of ovarian cancer, these ovarian stimulation protocols increase the risk of recurrence. So I think that they are safe if we apply this protocol. But of course, we need that the oncologists allow us to delay the start of oncology for 1 or 2 weeks. The treatment must start as soon as you see the patient. It doesn't matter the moment of the period in which the patient is. If she's not in the follicular phase, you can start with antagonists to monitor estradiol, and when estradiol has dropped to less than 50 picograms per ml, you can continue with the antagonist and start with the stimulation. The administration of aromatase inhibitors, 5 milligrams per day for 4 days, and administration can also be extended until the low estradiol levels are reached. Gonadotropin daily dose is 150, the recommended dose. Start antagonists when the largest follicle reaches 14 millimeters in the mean diameter. Ovulatory discharge with a bolus of generase agonists, and post-aspiration administer letrozole or antagonist in order to shorten the luteal phase. For those patients having hormone-sensitive tumors and being reluctant to receive ovarian stimulation, you can also propose them to have in vitro maturation, and in those patients also with no time for IVF before starting oncologic therapy. And in these cases, it seems that IBM is more efficient when it's performed before oocyte vitrification. So it's better to do IBM, and when you have mature oocytes, then you can vitrify them. And finally, the other strategy that cryopreservation offers you is to cryopreserve slices of ovarian cortex. And here we have to pay tribute to Jacques Donnet, who in 2004 published in Lancet the first live birth after applying this technique. Nowadays, we have information on 20 babies born around the world in different, some of them after a spontaneous conception, some of them after IVF, but all of them after orthotopic transplant in the peritoneal cavity in the ovarian pocket. We know this is the numerator, but we don't know the denominator. We don't know how many graftings have been performed in the world. We don't know how many retrievals of ovarian cortex have been performed. This is why the International Society for Fertility Preservation has started a world register in order to have information on the real efficiency of this technique. So far, we know that these graphs last for quite a long period of time. We have information from Klaus Diederik and Sherman Silvet on 3 cases of ovarian patients in which the ovarian cortical strips have lasted for more than 7 years. And from these 3 women, 8 healthy babies have been born. And we also have information that this technique, you should pay attention to the etiology of this malignancy, because some of the neoplasias are known that could affect the ovarian tissue, and you have the risk of reintroducing the disease by grafting ovarian tissue that could contain some malignant cells. And we have recent information, is a very interesting work that from Klaus Andersen group in Denmark, and is going to be published soon. And what they did is very interesting. They sent a questionnaire to a group of 143 patients with a previous unilateral oophorectomy for freezing by laparoscopy, maximum age 35 years of age, and all of them suffering from different malignancies, and all of them with malignancy with a potential risk of premature ovarian failure greater than 35%. These patients were followed up for a mean period of time of 58 months, and the global risk of permanent ovarian failure was 22% only. So this means that even in those patients, let's say at high risk of permanent ovarian failure, only 22% of them have later on experienced a permanent ovarian failure. The risk was lower in breast cancer patients and higher in patients suffering from leukemia or having received a bone marrow transplantation. And some of those patients have tried to get pregnant, and 41 out of the 57 achieve a pregnancy. So apparently, according to this information, the ovarian function and fertility potential after treatment is not affected in the vast majority of those patients. This is an interesting clinical observation. So, just to conclude, which are the options that we have nowadays for preserving fertility in women? If ovarian stimulation is possible, embryo or oocyte cryopreservation. The advantage of preserving or vitrifying oocytes is that the ethical implication that you involve in the procedure is much less than if you freeze embryos. If ovarian stimulation is not possible, you can either to preserve slices of ovarian cortex, or you can aspirate antral follicles and to perform in vitro maturation of oocytes and afterwards vitrification of them. I think that from a clinical perspective, the use of general analogs is not clear for me, and in cases of abdominal radiotherapy, ovarian transposition can be proposed, and fertility-sparing surgery whenever possible. And for the future, we have different options. We have the possibility of using regenerative medicine to either to produce new gametes or artificial gametes. We can use isolated culture of follicles or oocytes. But I think that for the future, the most important point is to have information for both, for patients and for professionals, for oncologists, because as you can see here, this is a questionnaire sent to different pediatric oncologists in the US, in Florida, in the most important centers of pediatric cancer. Most of the pediatric oncologists were aware of fertility preservation, but they did not think that it was their role to explain this strategy. None of this pediatric oncology had received any formal training. 50% of them would like to learn more about fertility preservation, 1/4 of the pediatric oncologists considered fertility preservation to be a high priority topic for discussion, and half of the believed parents were either uncomfortable discussing fertility preservation or were so focused on oncologic treatment they do not want to consider fertility preservation. Most physicians felt that girls were more interested than boys in preserving fertility. None of the pediatric oncologists surveyed was aware of any guidelines on fertility preservation, while in the States there are the Oncofertility Consortium, there are different networks that provide this kind of information, but there is a gap between the technical possibilities and the access of the patients and the professionals, and about 30% of the pediatric oncologists said that they routinely gave patients educational literature, but about fertility preservation. And the last slide, this is another group in the States. They sent a questionnaire to patients. The response rate was quite good, and the high knowledge scores of fertility preservation were associated with college education, higher income, primary diagnosis of breast cancer, additional contact with fertility preservation specialists following the fertility preservation consultation, and use specific reference websites available in the state. We had in Barcelona a year ago a consensus meeting with most of the Spanish group and some foreign colleagues, some of them present in the audience, and we established a guideline that are going to be published in the upcoming months, and it will be my pleasure to invite you to our next meeting of the International Society for Fertility Preservation, which is going to be held in Valencia next November, and we are organizing Tony Pellicer and I, and it will be a good time to exchange knowledge and to see you all there. Thank you very much for your attention, and thank you, Andrea.